Welcome, and thank you for joining us in this thoughtful review of acute kidney injury and acute renal failure associated with cardiac surgery. In this webinar, you'll hear from international experts, which include Mark Stafford-Smith, Rob Baker, and Jeremiah Brown, where we'll discuss various phases of care and themes will emerge that will help clinicians and their teams improve patient care. We would like to thank the Society of Thoracic Surgeons and the Task Force on Quality Initiatives. My name is Kevin Lobdell, and I'm with Atrium Health in Charlotte, North Carolina, where I'm the Professor and Director of Regional Cardiovascular and Thoracic Quality Education and Research. I have no conflicts to disclose. As aforementioned, we'd like to reinforce the value of the phase of care approach popularized by Frank Shannon, Rich Prager, and colleagues at the Michigan Cardiovascular and Thoracic Society. Our understanding of acute kidney injury is evolving rapidly and has been marked by a series of classification schemes, starting with RIFLE in 2002, the Acute Kidney Injury Network in 2004, and the Kidney Disease Improving Global Outcomes Group in 2012. Version 2.90 of the SDS National Cardiac Database defines acute renal failure as an increase in serum creatinine to 3 times baseline, or a creatinine that's greater than or equal to 4 with an acute rise of at least 0.5. Additionally, a new requirement for dialysis postoperatively equals acute renal failure. In 2005, Chertow and colleagues were one of the earlier groups finding correlation between small changes in creatinine and death, length of stay, and increased cost. Subsequently, there's increased sensitivity to small changes in creatinine and understanding of the incidence and impact of acute kidney injury in cardiovascular and thoracic surgery, where acute kidney injury may affect between 9 and 49% of patients. In fact, in our 2016 publication of Failure to Rescue, in 604,000 CABG-only patients, acute renal failure was demonstrated to have the highest correlation with mortality at 22.3%. The Virginia Cardiac Surgery Quality Initiative demonstrated that acute renal failure had an additive cost of $49,128 and correlated with an extra 2 weeks in index hospitalization. Furthermore, a 2018 Annals of Thoracic Surgery publication suggested that a 10% improvement in acute kidney injury associated with cardiac surgery could save an estimated $100 million a year in index hospitalization costs. Brown and colleagues showed us that there are also long-term ramifications associated with acute kidney injury, where those patients that suffered from stage 1 AKI had a 31% increase in readmission risk and a 56% increase in 5-year mortality, whereas those that suffered from stage 2 and 3 acute kidney injury had a 98% increase in readmission risk and a 348% increase in 5-year mortality. Next, you'll hear from Mark Stafford-Smith, who's Professor of Anesthesiology and Vice Chair of Education, Director of the Fellowship Education at the Duke Heart Center in Durham, North Carolina. Welcome, Dr. Smith.
My name is Mark Stafford-Smith, and I'm going to talk to you about the anesthesia perspectives of cardiac surgery-associated acute kidney injury. As you've already learned, it's a very serious and common complication associated with poor outcomes. Unfortunately, the story of preventing it or treating it has been a rather unsuccessful effort, as evidenced by a myriad of studies with interventions and prophylactic efforts that have not been successful. Therefore, we have to take a step back and approach the problem from a strategy of risk avoidance to diminish the renal insult burden across patients in our practice. The basic mechanisms involve ischemia reperfusion and sepsis inflammation, and this informs the strategy we are going to take. Pathophysiologic themes obviously include reducing oxygen demand and improving oxygen supply, in addition, reducing inflammation in the kidney and systemically. With regard to the anesthesia plan, renal risk can be reduced in some ways, or retrospective studies would suggest so, through preoperative optimization. First, to avoid, when possible, contrast exposure within 24 hours of surgery, although retrospective studies suggest that no longer is necessary than 24 hours. In addition, preoperative medications, including loop diuretics and possibly ACEs and ARBs, may be benefited from being withheld prior to surgery for up to 48 hours. In contrast, statins can be continued, although there's no suggestion that they protect. What is notable is that while it is a valuable tool to monitor urine output to get a sense of volume management, the volume of urine very commonly drops during surgery and anesthesia, and oliguria is an extremely poor marker of acute kidney injury risk for this regard. Therefore, it shouldn't be used immediately perioperatively as a guide to kidney function. Further moving to the anesthesia plan, I frankly think the hands of the user are probably the most important thing with most anesthesia techniques rather than whether they are protective for the kidney. However, there does seem to be some reasonably compelling evidence that use of epidural anesthesia when appropriate is associated with reduced risk of acute kidney injury. This has been demonstrated in prospective trials, randomized trials. Fluid selection obviously is important, and as we now know, the use of hydroxyethyl starch solutions in the presence of sepsis leads to greater levels of mortality and patients requiring dialysis. Therefore, generally this is now avoided in high-risk patients having cardiac surgery. More contentious is the use of normal saline, or 0.9% normal saline. A retrospective study presented in JAMA, which looked at 2 periods of time, one with a strategy of avoiding normal saline whenever possible, and one with more liberal use of normal saline, suggested lower rates of acute kidney injury when normal saline was avoided. More recently, the LICRA pragmatic control trial did not demonstrate similar outcomes with avoidance of normal saline. Furthermore, management of acute anemia as it occurs during cardiopulmonary bypass and interventions with transfusion are associated with acute kidney injury risk. All of these studies have been retrospective, and they seem to demonstrate an elbow in the curve with increasing rates of acute kidney injury as the hematocrit dips below 20 or 21% during cardiopulmonary bypass. This seems to occur irrespective of whether the patient is transfused or not, and in fact transfusion itself adds a risk of acute kidney injury. Although a study actually suggested that anemia is less well tolerated during cardiopulmonary bypass when hypotension is also present, this has not been reconfirmed in a study that was looking to try and examine this question. However, in a patient population where blood pressure management occurs without cardiopulmonary bypass, the duration of time when the blood pressure mean is below 55 seems to correlate quite tightly with the degree of acute kidney injury or the risk of acute kidney injury. Furthermore, in terms of optimizing perfusion, many will look towards goal-directed therapy. And as we know, there are 3 different approaches to this. One involves inotropes only, one involves fluids only, and finally there's a combination of fluids and inotropes. And what is interesting is that it appears that it is the influence of inotrope-based goal-directed therapy that seems to reduce the risk of acute kidney injury, and this should be considered when designing a perfusion strategy with goal-directed therapy. In a study at 26 German heart centers, they noticed considerably different rates of acute kidney injury across centers, despite very similar risk profiles. The intensive care unit directors were all given simultaneously a questionnaire to ask what prevailing practice was at their intensive care units. And what came out was rather interesting. In particular, intensive care units that preferred vasopressors such as norepinephrine had lower acute kidney injury rates on average compared to those that preferred epinephrine or dopamine as vasopressors. This was actually also true in terms of inotrope selection, where epinephrine as the preference was associated with lower rates of acute kidney injury relative to selection of dopamine. Clearly, this is a very loose association between therapy strategies and acute kidney injury rates, but these intensive care unit directors did not know even that they were being compared to other intensive care units for the rates of their use of certain agents. A lot of attention has gone towards glucose management during cardiac surgery and following cardiac surgery and in other settings. This followed the Vandenberg trial many years ago now. Unfortunately, these have not demonstrated any value in terms of reducing the rate of acute kidney injury. And furthermore, while tight glucose control is not associated with improved renal outcome, there does seem to be some association of extreme hypoglycemia with adverse cardiovascular outcomes. So in summary, postoperative surgical AKI is a common and serious problem that we have very difficult time predicting, and certainly our current treatments, once it occurs, are poor to none. Therefore, at least from the anesthesia point of view, a best practices approach to avoiding AKI in the first place is the best strategy to reduce the AKI burden across patients. This involves preoperatively preparing the patient by adjusting medications and avoiding toxins, including contrast nephropathy, and managing the anesthetic to minimize renal insults, including the consideration for neuraxial anesthesia when it's available or relevant, appropriate fluid and inotrope therapy with goal-directed therapy strategies involved, avoidance throughout the case of loop diuretics unless the need is for volume management, not for renal protection. Appropriate avoidance of extreme anemia during cardiopulmonary bypass seems to be prudent, and when this can be avoided without transfusion, that is preferable. Hypotension is only of major significance if it's unrelated to cardiopulmonary bypass. And finally, glucose therapy, management of glucose for tight control, that is, say, below 130 milligrams per deciliter, does not seem to be associated with improved renal outcome, but does seem to add risk to the patient. Finally, there are some pieces of evidence that suggest that hyperthermia during cardiopulmonary bypass is associated with more acute kidney injury. Thank you.
And next we'll hear about perfusion management in cardiac surgery from Dr. Rob Baker, who's Professor of Cardiac Surgery Research and Perfusion at Flinders Medical Center and Flinders University in Adelaide, South Australia. Welcome, Rob.
Hi, I'm Rob Baker from Flinders Medical Center in Adelaide, South Australia, and I'm continuing our webinar on cardiac surgery-associated AKI, looking at perfusion management. I have no disclosures relevant to this presentation. This is data from the Australian and New Zealand Collaborative Perfusion Registry looking at the incidence of acute kidney injury in the centres that contribute to the collaborative data set. You can see there's variation between 7 and 8% incidence up to 20%. And we know that with different ways of reporting acute kidney injury, this could be as different as up to 50 and 60% incidence rates reported by some centres. Now, kidney injury associated with cardiopulmonary bypass is unique as it occurs in an environment that's able to be modified. We're actually able to make clinical practice changes to decrease the likelihood of acute kidney injury in our patients. In this webinar, we're going to look at a range of factors, and I'm going to focus on those related to cardiopulmonary bypass, and specifically these factors that I've listed here. So I'll start looking at pressure and flow. We know that reduced pressure or reduced blood flow to the kidney is detrimental. During bypass, we tend to run at a cardiac index that's lower than normal, something in the range of 1.8 to 2.4 litres per minute per metre squared. We tend to run lower bypass pressures, often in the range of 50 to 60, and we lose pulsatility. But probably the biggest factor is there's enormous variation in the way that we practice. This paper by Kanji, published in 2010, looked at the effect of changes in mean arterial pressure between before bypass and during bypass and bypass flow on acute kidney injury in a high-risk cohort of patients. And they were able to demonstrate that when the change in mean arterial pressure between pre and on bypass was more than 26 millimeters of mercury, we had a large increase in the odds ratio of likely cardiac surgery-associated kidney injury with an odds ratio of 2.8. However, when flow was maintained, it was actually predictive with an odds ratio of 0.3. It was beneficial. In this plot here, this is data from the ANZ CPR registry, but this is from 20,000 patients. On the vertical axis, we have the average bypass cardiac index. On the horizontal, the average mean arterial pressure. And the colour graduations are looking at the predicted probability of acute kidney injury. If we look in the left-hand lower quadrant, we can see that as cardiac index is reduced, as mean arterial pressure is reduced, then we have an increased probability of acute kidney injury. In 2015, NAM published this meta-analysis looking at cardiac surgical patients and the effect of pulsatile flow. This looked at 9 randomised controlled studies where acute renal insufficiency was defined as a 50% increase in creatinine over baseline. Looking at their meta-analysis results, specifically the top part of this graph, looking at acute renal injury, we see that the risk ratio was 0.52 in favour of pulsatile flow. So pulsatile flow decreased the likelihood of acquired kidney injury with cardiac surgery. Looking at temperature, we know that the effect of bypass temperature appears to be equivocal with respect to the development of acute kidney injury. However, rewarming, as shown in the temperature management guidelines published by the STS, the SAA and AMSEC, has been shown to be important in terms of avoiding cerebral hypothermia, and we should try and keep our temperature below 37 degrees. But how does that impact upon renal injury? This study by Newland and the ANZ CPR group, published in 2016, looked at the impact of rewarming temperature on acute kidney injury. They looked at it in a prospective manner, so 6,900 patients in a multivariate analysis and 2,044 in a propensity match study. And in this Lowers plot, looking at mean rewarming temperature on the horizontal and probability of AKI on the vertical, we can see that when the temperature was above 37 degrees, there was an increased probability of acute kidney injury. And in their multivariate analyses, both in the adjusted group, in which there was a propensity score, the 6,900 patients, and in the propensity matched group, hypothermic perfusion for, in this case looking at 10-minute intervals of hypothermic perfusion, had an odds ratio of 1.4 for acute kidney injury. So it increased the likelihood of patients having kidney injury. So something that we should avoid. Now looking at the duration of bypass, Palumbo in 2007 published this paper looking at developing a risk score for the occurrence of acute kidney injury following cardiac surgery. And they demonstrated that bypass times greater than 120 minutes were associated with an odds ratio of nearly 2.5 times for the development of acute kidney injury. This was supported by this work from Del Duca from McGill University, where once again they showed that increased duration of bypass was associated with increased odds of developing cardiac surgery associated acute renal failure. Now, why is this important? Well, the duration of bypass is modifiable. We can reduce it by working as a team. We can reduce it by planning our procedures in a better way, optimising the workflow during bypass, and all members of the cardiac surgery team can impact upon this. Now looking at hemolysis. Hemolysis, as we know, occurs due to the blood passage in the oxygenator. It is often associated with over-occlusion of the arterial roller pump, causing an increased release of plasma-free hemoglobin, which we know is a nephrotoxin, causing damage to the kidney structures, which can result in post-operative injury. In 2014, Winsert and Co. from Sweden published this paper looking at hemolysis during cardiac surgery to test the hypothesis that hemolysis during cardiac surgery was actually a consequence of bypass, caused an increase in nitric oxide consumption, and contributed to acute kidney injury. In this graph, you can see patients with and without acute kidney injury, without in the white boxes, with the greyed boxes. And we can see during the bypass period, there's a significant increase in the release of plasma-free hemoglobin. Now looking at hemodilution and transfusion, we know from the blood management guidelines of the STS that it's very important to manage hemodilution and transfusion carefully, and it's a multi-modality approach that's important. The literature is very consistent with studies demonstrating an association between anemia, lowest hematocrit, and the likelihood of acute kidney injury on bypass. And similarly, there's a wealth of literature looking at transfusion and acute kidney injury. In 2005, Marco Ranucci published this paper looking at the effect of oxygen delivery during cardiopulmonary bypass on acute renal failure. And it was really the first time that goal-directed therapy, or the concept of goal-directed therapy, had been applied to cardiopulmonary bypass. Now, the study was performed in 1,048 patients and looked at the effect of lost hematocrit and lost oxygen delivery on both acute renal failure, shown in the top graphs, and peak serum creatinine, shown in the bottom two graphs. And we can see that there's a clear relationship with lowest hematocrit and these outcomes, and similarly with oxygen delivery. In actual fact, Renal demonstrated that the best predictor of acute renal failure was the lowest oxygen delivery, with a critical cutoff failure of 272 mils per minute per metre squared. In 2017, we published this paper looking at lowest oxygen delivery. We looked at the amount of time spent on bypass below a critical value of 270 mils per minute per metre squared. So we looked at it in a slightly different way. In this Lowers plot, we can see that as the amount of time, the area under the curve with oxygen delivery less than 270 increases, shown on the horizontal axis, the probability of acute kidney injury increases. And in the multivariate logistic regression that we performed, we were able to show that the amount of time with an area under the curve less than 0 increased, you're more likely to have acute kidney injury with an odds ratio of 2.7. This can be demonstrated in this plot, contour interaction plot, that shows the interaction of the area under the curve for DO2 on the vertical axis and transfusion of 0 to 3 units on the horizontal, and the prediction of the probability of acute kidney injury. And the plot indicates, if we look at the dark blue area, that the lowest probability of acute kidney injury occurs when there was no interaction between oxygen delivery and red blood cell transfusion. That occurred when the area under the curve was greater than 0. Whilst when we look at the area under the curve less than 0, we can see that an indication becomes apparent. This study was published in 2016 by Magruder from Johns Hopkins. It was a small propensity match study which looked at a similar idea in terms of looking at a goal-directed perfusion strategy, but they looked at a variety of different goals or aims to give an optimal perfusion strategy. But we can see some of them are very closely aligned to this idea of goal-directed perfusion in terms of oxygen delivery. And one of the factors they looked at was maintaining DO2 greater than 300 mils of oxygen per minute per metre squared. And they showed that there was a significant reduction in their GDP implementation group compared to their control group using this strategy. So once again, more data supporting the role of goal-directed perfusion. Currently, there's a multi-centre prospective randomised trial under consideration for publication from Marco Rennucci and co-investigators in the GIFT trial. And this was a trial designed to test the hypothesis that a strategy based on a goal-directed perfusion aiming to avoid a low DO2 below a critical threshold would be effective in limiting the post-operative acute kidney injury rate. And in these preliminary results, looking at the overall study population, looking at the AKI1 on the left, we can see that there was a significant reduction in AKI1, and also looking at the same endpoints for shorter bypasses, or bypasses I should say between 1 hour and 3 hours, you can see that the AKI1 rate was reduced, as was in both cases the NEAKI. So in summary, I think that it's really important to recognise, or to take home from this part of the webinar, that what we do during bypass is incredibly important, and it is modifiable, and we can impact patients' kidney outcomes. Strategies looking at pressure and flow, avoiding hypothermia, looking at controlling the length of bypass, looking at minimising hemolysis, looking at managing hemodilution and transfusion, and looking at oxygen delivery can all work together to help our patients minimise or reduce the likelihood of developing acute kidney injury post-bypass. Thank you.
Thank you, Rob. Next, we'll discuss acute renal failure as it fit into our quality improvement program at Atrium Health, again in Charlotte, North Carolina. Once again, I have no conflicts. Our quality improvement program began in 2004. Major areas of focus in the cardiothoracic ICU included early extubation, goal-directed therapy, glycemic control, and blood management. Our quality improvement program in acute kidney injury aimed to educate the team about the risks of acute kidney injury associated with cardiac surgery, and we evaluated our processes through the various phases of care. We aimed to mitigate modifiable risk by developing an acute renal failure scoring system and utilizing evidence-based practices, which include delay after radiocontrast, attention to hemodilution on cardiopulmonary bypass, meticulous hemostasis to reduce the risk of anemia, transfusion, and reoperation, as well as glycemic control, goal-directed therapy, and early extubation. Our educational process included a thorough review of the literature. Our quality improvement program aimed to do common things uncommonly well, as we know it often leads to success. Goal-directed therapy and oliguria are inextricably linked, and we believe that the kidneys, while not smart, knew when they were not happy. We believe goal-directed therapy to be central to the acute kidney injury prevention. Shoemaker popularized goal-directed therapy, where they set physiologic goals, therapeutic strategies with the aim of mitigating risk of these untoward outcomes. The macro goals include blood pressure, cardiac index, systemic venous oxygen saturation, and urine output, while micro goals could include oxygen consumption, oxygen debt, lactate levels, and other biomarkers to augment the diagnostic modality and therapeutic tactics. A good example of goal-directed therapy in cardiac surgery ICU is that by Osawa, where they reported on 126 patients randomized to cardiac output-driven algorithm with primary outcome of a composite endpoint of 30-day mortality and major complications. They demonstrated that goal-directed therapy may significantly reduce complications and length of stay for cardiac surgery. Kapoor et al. Correlated goal-directed therapy efforts with reduced length of stay, the duration of inotrope use, and a more rapid decline in lactate levels after surgery, as well as lower level of biomarkers associated with complications. In addition, intraoperative goal-directed therapy has been studied, and the risks of acidosis, AKI, and respiratory insufficiency may be mitigated through these efforts. The optimal goals for goal-directed therapy, their means and rate of achievement, their interactions, and the potential to mitigate specific complications such as AKI requires further investigation. Additionally, the cost effectiveness and value of goal-directed therapy has been studied in surgical patients but remains to be demonstrated in cardiac surgery. We're certain that additional insight will develop through the investigation of proteomics and genomics. As aforementioned, we solidified and institutionalized our risk assessment and mitigation strategies with multidisciplinary work groups through the various phases of care. Our advanced care practitioners guided the goal-directed therapy, where 5% albumin was typically used for volume expansion, inotropic support was commonly dopamine and or milrinone, and vasopressors included neosynephrine or vasopressin. The physiologic variables that we utilized included systemic blood pressure, and we would always compare that to pre-op, cardiac output with close attention to preload, afterload, and contractility, as well as systemic venous oxygen saturation and urine output. Through observation, we demonstrated and record the typical pattern seen in the first hour upon arrival in the cardiothoracic ICU, where the patient's required volume demonstrated increased need for inotropic support as opposed to less, and we also demonstrated that we had increased cardiac output and decreased SpO2 as the patients rewarmed. Oliguria was monitored closely and aggressively evaluated and treated in a routine manner. This slide depicts our results with acute renal failure following the STS definition at the time, which started at 9% in 2003 and improved to 0.6% in the 30 months between 2014 and Q2 of 2016, with 0 cases of renal failure in 2014. One can impute an annual potential savings of approximately $1.3 million with this improvement. Next, we'll hear on the mitigation of acute kidney injury from Jeremiah Brown, who's Associate Professor at the Dartmouth Institute of Health Policy and Clinical Practice Epidemiology at the Geisel School of Medicine at Dartmouth University. Welcome, Jeremiah.
Hello, this is Jeremiah Brown. I'm Associate Professor at Dartmouth, and I'll be discussing with you the mitigation of acute kidney injury and cardiac surgery. I have no conflicts of interest to disclose. I wanted to start with a brief word about AKI biomarkers in clinical outcomes. AKI biomarkers like NGAL can be useful subclinical outcomes when investigating AKI preventative strategies. It is also important to evaluate hard clinical outcomes like death, length of stay, CKD progression, and dialysis, like the TRIBE AKI Consortium did in this paper. Now I will review for you the strategies for renal protection in cardiac surgery. We'll discuss several areas, including bypass management, ischemic preconditioning, pulsatile flow, and transfusion. I wanted to start with a word about pharmacological strategies that have been investigated for renal protection. These have included dopamine, phenoldiazepam, N-acetylcysteine, aspirin, beta blockers, calcium channel blockers, and insulin. However, all of these pharmacological strategies have mixed evidence. Strategies needing further investigation, but that also show some promise, include the use of mini-circuits, heparin-coated circuits, leukofiltration, antioxidant agents, and however, dopamine should be avoided for AKI prevention. I'd like to spend most of our time on the strategies showing the most promise for AKI mitigation. These include the reduction in blood use and age of blood products, timing of cardiac catheterization prior to surgery, remote ischemic preconditioning, pulsatile perfusion, and KDICO guideline implementation. Starting with the use of blood and age of blood products. Returning to the study that Dr. Colleen Koch conducted in 2008, they showed that patients randomized to receiving newer blood less than 2 weeks old compared to older blood greater than 2 weeks old had better survival, and they also had significantly lower rates of renal failure. This is problematic because most cardiac surgery programs, due to the volume of blood use, often receive older blood even though it may be harvested by that site. Renucci and colleagues also reported that patients receiving newer blood products had lower rates of AKI, 0.8 versus 5.2%. However, that finding was not statistically significant, but showed a trend. When we looked at the use of packed red blood cell products in the Northern New England regional data, we found that patients receiving 1 or 2 units of packed red blood cells during or after cardiac surgery had significantly lower rates of dialysis and also significantly lower rates of severe AKI. There's also the issue of timing of cardiac catheterization from the time to cardiac surgery. Renucci and colleagues also conducted a study looking at the number of days between cardiac catheterization and cardiac surgery. And they found that waiting at least 1 day from the diagnostic cardiac catheterization to surgery decreased the peak postoperative serum creatinine, suggesting a decrease in AKI. When we looked at the rate of AKI in the Northern New England regional patients, we stratified patients by having a cardiac catheterization during the same admission of cardiac surgery or prior to the admission for cardiac surgery. It was conducted either at that site during a prior encounter or at another site prior to transfer to the surgical site. And those patients that had a cardiac cath prior to the index admission for cardiac surgery had a lower rate of AKI at 33.7% compared to patients having a cardiac cath during the same admission. They had an AKI rate of 50.2%, suggesting, along with Renucci's findings, that we should consider spacing out the diagnostic cardiac cath from cardiac surgery by at least 1 day or a prior admission if possible to allow kidneys to recover and filter out contrast agents where patients may be having contrast-induced nephropathy and providing time for them to heal. I'd like to move on to discuss remote ischemic preconditioning. In a study by Ali and colleagues, they showed that serum creatinine was significantly lower among patients that were randomized to ischemic preconditioning compared to patients that did not, suggesting that we might find a significant reduction in AKI. We conducted a meta-analysis evaluating ischemic preconditioning among randomized trials, and we found a 31% significant reduction in AKI or dialysis for patients randomized to remote ischemic preconditioning. There are now new pulsatile flow technology available for cardiac surgery programs or being developed now and in evaluation. For patients undergoing coronary bypass graft surgery or CBB, pulsatile perfusion may be considered to minimize the rise in creatinine and reduce the risk of AKI or increase urine output. This evidence comes from a meta-analysis we conducted looking at postoperative serum creatinine, where postoperative serum creatinine was significantly reduced among those randomized to pulsatile perfusion. Urine output was significantly increased for those randomized to pulsatile perfusion, and AKI was significantly reduced among patients randomized to pulsatile perfusion. It is another technology to consider to mitigate the risk of AKI for patients undergoing cardiac surgery. I would like to close by evaluating the PREV-AKI RCT that recently reported implementation of the KDIGO guidelines and development of a surgical bundle to prevent AKI. Their surgical bundle, based off of the KDIGO guidelines, included the avoidance of nephrotoxic agents, discontinuation of ACE or ARBs inhibitors for 48 hours after surgery, close monitoring of serum creatinine and urine output, avoidance of hyperglycemia for the first 72 hours after surgery, consideration of alternatives to radiocontrast agents, and close hemodynamic monitoring by use of a picocatheter with an optimization of the volume status and hemodynamic parameters according to a pre-specified algorithm that we show here to the right in Figure 1. They found a 16% significant reduction in AKI and a 15% significant reduction in severe AKI. And this approach to guideline adherence is yet another strategy to try to mitigate AKI in cardiac surgery. Thank you for your time.
Thank you for viewing the Society of Thoracic Surgeons Task Force for Quality Improvement webinar on acute kidney injury associated with cardiac surgery. Please contact Sydney Clinton with any comments. Again, thank you.